this is a particularly virulent or bad form of cholesterol because it is very good at depositing into your arteries and causing calcification and inflammation in your arteries. It's basically a cholesterol molecule with a protein chain attached to it that makes it really easy for this to get into valves and arteries, etc. This is probably the reason that many people with normal levels of cholesterol get heart attacks. A lot of people have heart attacks and their cholesterol is normal. And everyone's like, why? Well, because it's LP little a. It's a specific form of cholesterol that we've never tested for in the past until very recently. So number one, everyone needs to get tested for LP little a. Okay. It should be part of the normal cholesterol panel that we do for everybody. If you've never seen this on your blood work, insist on checking it because 15% or more people have it.
All right. Well, it's a real pleasure to have on the show again, Dr. Darshan Shah.
Zora, it's such a pleasure to be here. It's so honored you asked me back.
Oh, it's so great to have you back. I really connected you with our first episode, which I'll have in the show notes, because we talked so much about all things menopause. We talked about testing. We talked about your wellness wheel. That show was jam-packed, but I still had like 20 more questions.
Fantastic.
Yeah, and I found you so intriguing, and I really liked the way you responded, and you just, yeah, it's so easy to talk to. So I said, let's get you on again, and we'll have a part two and all the things that we still have yet to cover. So are you ready?
Let's do it. Part two.
So let's talk about the therapeutic plasma exchange. You kind of gently brushed on it at the end, but we just didn't have time to take a deep dive into it. And since we're speaking to a woman going through this menopause transition, she has some of these symptoms. I'm wondering if TPE, this therapeutic plasma exchange, can have anything to do. I'll help her at this point. So maybe explain what it is and then how we can use it for women in menopause.
Yes, absolutely. So therapeutic plasma exchange is a procedure that was approved by the FDA back in the 70s. And it is basically a machine that we have in our office that allows us to remove blood from one arm, put it through a giant centrifuge, separating the plasma from the blood cells. Okay. And then we can re-inject the blood cells with albumin back into your arm and take that plasma and basically throw it away. Now, why would we want to do this? So in the hospitals, we've been doing this for decades now. If someone has, for example, a drug poisoning, that drug lives in the plasma, specifically bound to albumin, and you can completely eliminate that drug from someone's plasma by removing the plasma completely and throwing it away. And a lot of times, like you'll see someone with a drug overdose come in with some certain types of drugs, and you do the plasma exchange, and they're completely recovered. Other reasons we've done plasma exchange in the hospital is when someone's going through an autoimmune crisis. And why does plasma exchange help there? Well, because your immune cells, they form these proteins called immune globulins, and those also live in the plasma. And these immune globulins are wreaking havoc throughout the body in someone in autoimmune crisis. And so we can do the plasma exchange, and the autoimmune crisis just literally goes away by doing the procedure. And so my reason for explaining all this to you is because everything that is floating around in our body lives in this fraction of our blood called the plasma. This is the liquid fraction of our blood. It is everything other than the blood cells. So what else is living in the plasma, right? Well, toxins live in the plasma, right? All the toxins that we measure for in a blood test, like heavy metals, we measure for PFAS, we measure for microplastics, all of that lives in your plasma. Another thing that lives in the plasma is inflammatory cytokines, the messenger molecules that create inflammation throughout our body. That lives in your plasma. When we do a blood test, we're sometimes measuring for cholesterol. High levels of cholesterol also live in your plasma. So there's a lot living in our plasma that our body is circulating to our liver and to our kidneys to try to get rid of, okay? Or trying to get rid of it through other methods, such as the inflammatory cytokines bind to cells and create more inflammation, okay? So the idea here is if you remove all of that bad stuff that's living in your plasma in one fell swoop with a 2-hour, very comfortable procedure in our office, you reduce levels of toxins, you reduce levels of inflammation, you reduce levels of immune globulins that are creating autoimmunity, et cetera. And it happens in a 2 or 3 hour procedure extremely effectively. And so we've been doing this procedure now at Next Health Clinics for a couple of years now. We've done over 100 procedures, and we've seen massive improvements in people's inflammations, in their toxin levels, their heavy metal levels. Also, and they have autoimmune disease. We're seeing symptom improvement there as well. So it can be extremely helpful in these type of situations. And as far as a perimenopausal woman goes, well, many of her symptoms are exacerbated by toxin exposure, by high levels of inflammatory cytokines, et cetera. So it could be helpful. Now, I think that every person is an N of one, right? We've talked about this before. We have to see what's going on in your blood work, see if there's something that we can go after with the plasma exchange, and then recommend if this procedure will be good for you or not, and what cadence that we should be doing this procedure. So should we do this every 6 times in rapid succession? We do that a lot for people with like acute heavy metal toxicity, or should we do it quarterly for people that are just trying to maintain longevity and low inflammation levels, et cetera? So there's all different protocols that we can do. It just depends on your individual blood work.
Interesting. So in the plasma, this is you mentioned toxins and cytokines and cholesterol, and not that cholesterol is a bad thing, but I guess maybe
No,
excessive. I don't know.
excessive, right? Some people have LP little a. Are you familiar with LP little
Yeah.
a?
Yeah. Maybe
Yeah,
you want
some
to
people have
explain a little
that.
bit. Yeah, that for those who
Yeah.
know what it is.
Yeah, so this is a perfect example where plasma exchange is extremely beneficial. And now people don't even know this, but the American Heart Association recommends, or I think the American College of Cardiology recommends plasma exchange for people with LP little a. Now, LP little a is a genetic condition that people have. It's a specific form of, let's just say, cholesterol, high cholesterol, that is present in about 15 to 20% of people that we've never checked for before. And this is a particularly virulent or bad form of cholesterol because it is very good at depositing into your arteries and causing calcification and inflammation in your arteries. It's basically a cholesterol molecule with a protein chain attached to it that makes it really easy for this to get into valves and arteries, et cetera. This is probably the reason that many people with high cholesterol, sorry, normal levels of cholesterol get heart attacks. A lot of people have heart attacks and their cholesterol is normal. And everyone's like, why? Well, because it's LP little a. It's a specific form of cholesterol that we've never tested for in the past until very recently. So number one, everyone needs to get tested for LP little a. Okay. It should be part of the normal cholesterol panel that we do for everybody. If you've never seen this on your blood work, insist on checking it because 15% or more people have it. Now, here's the bad part of LP little a. Not only is it particularly virulent, it also has no treatment. There's no medication to reduce LP little a. Okay.
Mm.
So the only way to get rid of this is by removing it directly from all the LP little a particles that are floating around in your plasma. All right. And so plasma exchange is a really effective methodology to remove LP little a. Now, there are some companies like Genentech that are making drugs going after LP little a. They won't be approved by the FDA for another 3 to 5 years. So in the meanwhile, if you have high LP little a and you have plaque in your blood vessels, this could be a really efficacious treatment that you should consider.
That's interesting. You've done over 100 of them and you're seeing great results. And I don't know a lot of people who actually take this procedure, but I'm wondering, so LP little a is
Mhm.
something that you say is genetic in terms of 15 to 20% of the population can't really do anything about it. You're just, sounds like hypercholesterolemia, where you're just, it's not that
Familial
you're doing anything
hypercholesterolemia,
bad, you're
right?
just born this way. So this is an
Right.
incredible solution, and without drugs. So even if they do make a drug, it's like, do I really want to take it? Because there may be side effects to that. Are there any side effects to the TPE?
Well, here's the beautiful thing about TPE. We're not giving you anything. We're just removing your plasma, right? The only side effects that can occur are those from removal of some of the good things that live in your plasma. Okay, so what are the good things that live in your plasma? Well, your hormones circulate in your plasma. The beauty there is that you regenerate your hormone within 24 hours. Another good thing that lives in your plasma also is stem cells and exosomes float around in your plasma sometimes. Those also regenerate very quickly. Most of your stem cells live in your organs and your tissues, but there are a few that live in your plasma as well. A lot of times we actually give people umbilical mesenchymal stem cells right after the plasma exchange procedure, just because it's a really good time to do it. You are a tiny bit more susceptible to infections because we are removing those immune globulins. So immune globulins are your body's surveillance system for infections. So you are a little bit more susceptible to infections after getting plasma exchange. Those regenerate typically in about 5 to 7 days, but we also give people IV immune globulins after the procedure. If they have a high risk of infection or they're traveling or something, we'll give them IVIG. Not everyone gets IVIG, but that's really it. And so side effects are really pretty minimal, in my opinion, and we've never seen a major side effect at all on anybody. It's a really well-tolerated procedure. Like I said, it's been used for decades in hospitals, only for emergency situations, and we're finally using it outside of the hospital now, which is really exciting.
And it's a procedure where you just lay in a bed or a chair, and then you have a needle, I guess, going in, you pulling out your blood, or And then you separate in the blood, there's the plasma, right? I can imagine you
Yeah.
can't isolate the plasma and leave the blood in, right? I don't know.
So here's the thing. If anyone's ever had PRP that's listening to your podcast, they know exactly this procedure, right? You've had PRP. They take a blood draw, right? And they put it in a centrifuge and they spin it. And then it separates into the red cells at the bottom. And there's this yellow layer on top. That yellow layer on top is your plasma. So we're doing that for your entire blood volume. Okay. Now we're not removing your entire blood volume at once. We're only removing about 150 cc's at a time because we're removing some, spinning it, and putting the blood cells back in with new albumin. And so it's happening constantly for 2 to 3 hours. You know what I mean? And so that's how the procedure works. It's basically like a giant PRP
So
session.
do you have two needles in your arms, like one going in,
Yes.
one going out, kind of a thing?
Yes, that's exactly right. Yep.
Is it painful?
No, not at all. You just sit there. It's just like having an IV. If you've had an IV done, it's pretty much the same procedure as far as you're concerned. You just have two IVs in at the same time.
Does it help with people who have mold toxicity?
It can, certainly. Yes, because it removes those mold toxins that are floating around in the plasma as well.
So you mentioned also in cytokines and inflammatory markers, and it helps with that. So it makes me think about those zombie cells, those senescent cells. Those are
Yes.
cells that just don't die, and they're causing havoc and they're causing problems for everything. We just want them to make that decision and die, and they don't. So does it help with that at all? Is there any role that TPE does for that?
So we have not specifically measured senescence markers in our patients, but what I will say is that there's a really great paper published about a year ago on the procedure, and they checked over 1,000 different markers of aging, and senescent cell clearance did improve in that paper.
Interesting. Are you doing anything in your practice to help people with senescent cells? You're not quite using that yet for just for senescent cells, but are you using any other treatments to help people with senescent cells?
And to be clear, like plasma exchange may help with senescent cells based on the paper I told you about that was published like a year ago on multiple biomarkers of aging and plasma exchange. So it may be helpful there as well. But yes, as far as senescent cells go, we provide them with targeted supplementation with things like fisetin, quercetin. We also really encourage longer term fasts, like 3 to 5 day fasts. Every quarter is kind of what we see as the optimal effect cadence for fasting. There's a really great product called Prolon that was developed to help people get through a fast with a few calories at least. And yeah, I mean, that's kind of where we're at with senescent cells. Also, lots of things help with cellular senescence and clearance of senescent cells, like high intensity intermittent training really helps. Getting good sleep helps. So just getting lifestyle modifications in place as well.
Yeah, actually, there is a lot that we can do. So it's funny you mentioned Prolon. Dr. Longo was one of my professors of gerontology at USC. And so I was very familiar with Prolon. I've done Prolon actually before. And yeah, I get the idea. And it seems to be very helpful for people. I would say, if you want to like clear senescent cells, you want to hit autophagy or you want to get jumpstart maybe a healthier diet and lifestyle. But whenever I see somebody using it for weight loss, I always think, well, you're going to gain it back. I don't know if you have, do you use it for weight loss at all?
No, not really. We use it for mainly gut resets and also for people that have that are looking to improve energy levels, et cetera. It's part of an overall longevity program. Definitely, we're not starting with fasting, but we're also once people get to that point where they've done all the lifestyle things, they're feeling pretty good. We use it kind of as the next thing that they could try to see if it even jumpstarts them even further.
Oh, cool. So just to wrap up on the plasma exchange, because this is such an interesting therapy. I got it when I get to LA. I want to try this because I think it's something that's quite unique. And like you said, maybe it's been in hospitals, but not. I don't know a lot of people who are doing it. Is it something that you need to do regularly? Let's take somebody who's got the heavy metals. Now, does she or he need to come in several times, or is this just a one-off and it's done?
Yeah, no, it's nothing's a one-off in medicine because unless you're having a surgery, right? Because our biology is constantly being exposed to the environment and we're constantly changing and we're aging and there's a lot going on in our biology and it goes on over time. And so unfortunately, like I tell everyone, like this is everything that you do, you need to keep doing in all of the interventions that we have in longevity and medicine, et cetera, except for pharmaceuticals, because you can reverse chronic disease and get off pharmaceuticals. And we're seeing that a lot. But the idea with plasma exchange, as far as frequency goes, it just depends on what we're going after. If you have high levels of heavy metals, for example, we may need to do the procedure once a week for 6 weeks to really clear those heavy metals. But if you're using it mainly for longevity purposes, quarterly is kind of what we recommend as a starting point. So we have some heavy longevity enthusiasts that want to do it more frequently. And then we're always measuring biomarkers and really optimizing protocols on an N of one basis, seeing how much are we really moving the needle for you and should we be doing it more frequently or less frequently. So it's always an individualized protocol.
Can I ask, is this expensive to do, or what's the price of one session?
Right now, one session is $8,000. So it is not cheap, but, and we do have packages for people that want to do 6 sessions as well. But yeah, definitely it is something that it is an investment at this point in time, mainly because it takes very specialized equipment, staff, and also we're giving you albumin to replace the plasma. And albumin is pretty expensive as well.
Really? Interesting. But where albumin, I know that it's a marker that I test when I want to look at my testosterone levels, but I never thought of taking it as a supplement, or I don't know how to replenish it if you were actually, I guess, low on it. Is it just a molecule you get and you just stick it in the IV and it's
Yeah, albumin is actually a big part of the procedure. So, albumin is a protein that lives in our blood. It's one of the most important proteins that live in our blood because it is a very large protein and has multiple functions. One function of albumin is it creates what's called oncotic pressure. So, the way anything works in biology is water kind of goes towards wherever there's molecules that'll suck it up. Okay. And so, to keep fluid inside of our blood vessels, we need to have albumin. Otherwise, the fluid would just leach out into our organs and you would die. And so albumin is critical because it keeps the fluid in our blood vessels and it creates the plasma, basically. The second thing that albumin does is it has receptor sites on it. It's a very sticky protein. So as you mentioned, testosterone, it floats around stuck to sex hormone binding globulin and albumin. Many hormones, many messenger molecules, toxins all stick to albumin. Albumin is actually going throughout your body, and it's what's bringing those toxins to your kidney and liver for clearance. Because of the environment that we live in, that is one of the most toxic environments ever in human history, our albumin is kind of saturated with all of these toxins that it's trying to get out of our body. And so when we do plasma exchange, we're removing all of your albumin. So we need to put that albumin, new albumin back in. How do we put the new albumin back in? Well, we have to buy it and we have to hang it as part of the solution that's going back into your body. So we're sometimes giving you 2 to 3 liters of albumin, actually.
Oh.
The nice thing about this albumin is it's fresh new albumin. So it's not bound up with toxins, it's not bound up with inflammatory molecules. And we're giving you brand new albumin that can now go and function so much better in your body.
Where does it come from? Is it synthetically made, or is it pulled out of an animal or human?
You pulled out of a human. So all these plasma donation centers, what they're doing is they're taking albumin from tested individuals. They're testing the individual for any type of infectious agents, and then they are bringing it to these massive centers throughout the world, United States being the number one place in the world that albumin is made, and they're completely purifying it. So you just have the protein left with nothing else bound to it, no other toxins, nothing left. And that purified albumin, this has been an industry in the world for decades now because it's used in hospitals every single day. We use albumin in trauma cases, we use albumin in the ICU, we use albumin. We've been using it forever in the hospital. It's just like IVs, like it's given very, very frequently. And most people like you've probably never spent a lot of time inside of a hospital, so you have no idea what it is. But being a surgeon and specifically a trauma surgeon, I use albumin every single day. And so it's something that is very common that in medicine, and more people are hearing about it now because of plasma exchange.
Okay, I had 2 hip surgeries. Is it something that would have been given to me in my IV along with all my painkillers?
Potentially, yeah, yeah. They most probably use it during the surgery to increase if your blood pressure went down. Hip surgery is one of these surgeries where you lose a lot of blood, a lot of fluid a lot of times, and so your blood pressure is going down. Sometimes the anesthesiologist will give you albumin.
Wow, interesting. Is there a risk for rejection because it's coming from another human being?
No, there's absolutely zero risk for rejection. Some people very rarely do have an allergic response to it, which is really strange because it might be to like the preservative that's in with the albumin, but very rare to have that, but no rejection risk.
Oh, good. Okay. I want to ask you because this plasma exchange completely reminded me of the research that Dr. Longo presented us in gerontology of these 2 mice that they hooked up, the young one and the old one, and then they exchanged their blood. And I know it's totally different, but what's that procedure called? And is
It's a
this in our
really great
future at
memory.
all? What?
Yeah, it's a really great memory that you had. So that's awesome. So this whole procedure is based on exactly that experiment that you talked about. It's called the very famous parabiosis experiment done by the Conveys, where
Yeah.
they hooked up an old mouse and a young mouse, and they saw that the old mouse got younger and the young mouse got older. And they're like, wow, this is amazing. There must be something in the young mouse that's making the old mouse younger. And a massive search was underway at that point in time for what's the molecule that's doing this. Turns out there probably are some molecules that are helpful, but no one's been able to isolate and turn one into something that we can give to somebody. However, some very astute clinicians thought maybe it's not something in the young mouse that is making the old mouse younger. Maybe we're removing something from the old mouse that's keeping it old. And that's where plasma exchange came. And turns out it is extremely powerful to remove the old plasma. We see this in many studies, both on mice, also on humans. Plasma exchange, when done in a human, and this is an incredible experiment that was also done by the Convoys. They did a muscle biopsy, a nerve biopsy, and a liver biopsy. After one plasma exchange procedure, all three of them got younger by biopsy. And so I think that's very important that you remember that parabiosis experiment, because that's the experiment that led to the use of plasma exchange outside of the hospital in this type of longevity setting.
Okay. All right. That's interesting. Never thought of it as being maybe removing something from the old mouse. And that's makes perfect sense now. Okay. I want to move on. And we only have, I don't know, like 10, 15 minutes left. And I don't know how we're going to plug through this, but
We have to do another part 3, Zora.
I know the part 3 because I only got through one question. But the other question I want to pick your brain on is NAD and NAD IVs, NAD injections, NAD supplements. And this is something we mentioned, Dr. Elizabeth Yorth. I was talking to you about her just before recording, and she's been sharing some stuff with her community, and I'm part of her community, and I'm just blown away. And she talks a little bit about the CD38, the NNMT. These are different molecules that are kind of problematic for NAD, but because it was everybody's taking NAD something to boost their NAD levels. So I know that you're offering this. I'm wondering how can you explain in terms of the benefits, so some great benefits, but then how do we offset any of these markers that may be bringing negative benefits to us?
Yeah, it's really interesting where the science is going with this. So IV NAD, let's talk about IV NAD in particular, right? As you mentioned, there's markers like CD38, and that could be degrading the IV NAD to where now there's a lot of talk about, like, are you really getting any benefit from doing IV NAD? And then there's other molecules like IV nicotinamide riboside, which is also called Niagen, that absorbs so much better into the cell because they're not having to be converted into NAD and NMN before they get intracellular. So I think there's a lot of that we need to discover with NAD. I do think that even though there's science showing that some of the NAD molecules does get broken down, we also have science showing that IV NAD does lead to increased intracellular NAD and mitochondrial NAD as well, and improved energy production, probably not to the level that we thought, but it is still helpful. And Niagen is a molecule that kind of bypasses that absorption mechanism and system as well. So I think it's, once again, is very N of one. If you do IV NAD and you find a benefit, there's probably a good reason to keep doing it. However, now there's a supplementation that Dr. Yorth is talking about that can kind of counteract some of the negative aspects, some of these other molecules and enzymes that break down NAD as well. So we're looking into using targeted supplementation with IV NAD together.
Is it 1-MNA at all that you're looking at? Or
that's the one. Yep.
Yeah.
Exactly. Yeah.
So I'm going to do a whole episode on it because I'm just learning more about 1-MNA. I've never heard of this before, but the way that I understood this, and you can explain, just tell me if I'm wrong or not, because I'm just very basic in my thinking, is that as we age, we lose our NAD, as well as spermidine, as well as melatonin, as well as like everything. Like we lose everything as we age.
Yeah.
And that's not a good thing, right? We need an NAD to function. And so the way I understand it is that you imagine we have a bucket and we have a bunch of holes in there, and it's could be because of the CD38 is eating up all of these molecules. Let's imagine making all these holes. So when you have a bucket and you're filling it with NAD precursors or NAD straight up, you're filling the bucket, maybe feeling good for a little while, but then eventually, if you don't get to the root cause of the problem, all these holes, then it's, again, I don't want to say wasted time, because a person maybe feel better, they're getting more energy, but eventually they may come down again. And I don't know how true this is or not, but that's the way I was understanding it.
Yeah, that's a really good way of explaining it, basically. And you're right. This is the problem. And 1-MNA might be the critical piece here because it's helping to fix those holes. And so this is exactly what we're looking into. And so I'm a little hesitant right now because I still think there needs to be more science and more research around this. And Dr. Yorth is definitely the world's expert in this, in my opinion. I'm just waiting for her to tell me what to do.
I also want to interview myself, Dr. William Seeds, and he also knows a lot about this as well. And I've just been listening. He's got a podcast himself, and I'm just diving into it. I'm like, this is whole of the world of, you guys are longevity experts and doctors are
Yeah.
treating the patient. So there's one thing in terms of what the research says, but I have to say clinical experience is gold because you're putting it to the test. Does it work with your patients or not? And again, maybe some do and some don't, but
I'm
let's
so
watch
glad you
the
said that.
space.
Yeah, I'm so glad you said that, Zora, because we try to make these blanket statements across every human individual. And what I can tell you being a doctor, talking to so many people, looking at all their, I look at literally maybe 30 to 40 biomarker panels a day. And I can tell you everything affects everyone differently. And we do have this kind of bell-shaped curve, right, in medicine where there's people that fall mostly in the middle. So most people get affected in the same way with different therapies in the middle of the bell-shaped curve. But when I say most people, that's only like 60% of people. The other 40% are one or two or three standard deviations away from the middle. And that's a big number. So to your point, IVNAD might still be very beneficial to somebody, kind of beneficial, not beneficial, or harm somebody. And you need to figure out where you are on this bell-shaped curve, not just with NAD, but with most interventions that we're trying with molecules, et cetera. And the same holds true with every intervention we're talking about, whether it be, the keto diet or it's blue blocking glasses. Like a lot of these things, they fall somewhere on that bell-shaped curve of how it affects your individual N of one biology. And so this is the title of my book that I'm writing right now is N of one, to really break this down for people and give them experiments that they can do and how they can track these self experiments and see if it's working for them. Because if it's working for you, you should do it. If it's not working for you, you should absolutely not do it. But don't fly blind. That's the
Yeah.
message.
Exactly. That's why we send in people like you to do these experiments until they can figure it out. But when is that book coming out?
It's about a year.
Oh, okay. We have to
Yeah,
wait.
I know. I'm sorry.
Oh, that's a brilliant idea. And this is why I always go back to biohacking menopause because everyone's going to have a different journey and a different experience. And hormone therapy will work well for one and horrible for another. But you can tweak and you can experiment and other than hormones as well and lifestyle and diet. And it's just in the end, especially when it comes to hormones and menopause, women are so confused. They don't know what to do. And they hear one thing and then another, and it's good and it's bad. And I'm just like, you know what? Let's just do an N of one experiment, try something just to feel better. And whatever that is, hormones or no hormones, I don't care. Just find out what it works for you. And that's why I love
Yeah,
biohacking.
exactly, Zora. And in my opinion, perimenopause and menopause is 100% an N of one situation every single time. And so you brought up a perfect example. Whenever you hear controversy, whenever you hear it worked for me, it didn't work for me, don't do it with equal amounts of fervor, it means you're in an N of one situation happening. You're in the middle of an N of one situation happening right now. And menopause and perimenopause is an excellent example of that. And for years, we've been told by the Women's Health Initiative, don't do hormone therapy because it could potentially cause cancer. Well, guess what? That was very N of one. That was in older women starting hormone therapy way too late, and they probably already had the cancers anyway. And so now we're just detecting them. And so what if you are a 45-year-old woman that is really, really suffering with symptoms and you have very low risk of breast cancer and you want to prevent breast cancer? Well, then hormone therapy might be right for you. And so it's one of these massive, I would say, tragedies in medicine that we just try to apply the same advice to everybody. And it just doesn't work that way.
Yeah, unfortunately. But hopefully we'll have a lot more experiments going on in the world with doctors and women and having experience treating women through menopause so that each doctor can say what is really working best for their patients. I think right now that we're still Wild West and let's try this and let's try that and or not at all. I don't even want to go there. Hormones are bad or go find someone else. That's unfortunately, yeah, it's evidently in medical school, you're not taught enough about menopause hormones, but we'll change. We'll hopefully change for the better.
I actually think we're almost there. I think we're
Think?
almost there. Yeah, because the messaging is coming out thanks to women and people like yourself, Sora, that the thinking was wrong. We need to look at this. And then also the testing is becoming more ubiquitous and women are demanding the testing be done. And there are more people that are trained in hormone replacement therapy as well. And so all of this is bringing more awareness and bringing more accessibility to to this problem. And I think we're on like the kind of that moment in time where everything's going to change and the tide will turn on this problem, hopefully.
Yeah, hopefully. And I just listened to your great episode with Dr. Sarah Zoll, not Gottfried anymore. And she was in, because she was like you, just trained more or less around the same time, and she was a little bit earlier, but she said that when she was treating women through menopause in her early years before the WHI, the Women's Health Initiative study came out, it turned everybody off hormones. She was thinking that everyone was a little bit, this pendulum was swinging a little bit too far on one side. Like, let's put every woman on hormones and not question things, just get her on it. And then the WHI came out, pendulum swung the other way, stop it. And so the conclusion that I heard from her was like, yeah, we'll be in a great space now. It kind of swung both ways, and hopefully we'll land in the middle with this new generation and have a lot more data, a lot more experience, and hopefully individualize and personalize each woman's experience through menopause if she goes on hormones or not.
Correct. Yeah, absolutely.
Good. I'm going to have the link to that show because that was a great show in my show notes. My last question, because I know I have to let you go. And this one just came to my head because you are testing, measuring, and assessing each patient's very individual. I want to hear your thoughts on breast screening. How do you recommend your patients who are in this menopausal age to, if at all, to go screen their breasts?
Yeah, right now, I used to be a breast cancer surgeon, so I was really deep into this before I changed into this kind of longevity sphere. And I know things are changing right now, and there's new testing modalities available that are coming that are going to be game changers for women. And I don't know when they'll be ubiquitously available, and there needs to be more testing around this as well to make sure they're efficacious. But right now, I think that the mammogram is still the gold standard. I think that MRIs provide a lot of additional data on top of the mammogram. And I also think the ultrasound also provides a lot of additional data on top of the mammogram. Even though it sounds crazy to do all three.
I've done them all.
Yeah,
I'm
exactly. Yeah, I mean, people think I'm crazy when I say this. I mean, the reality of the situation is you get incrementally more information with all three than you do with just one, two individually, one or two. And so I think it's really important to be working with someone who really understands the modalities and what they mean and your risk factors. If you have a genetic predisposition, a family history, dense breasts, all of those things, you might really strongly consider more than one of these modalities stacking on top of each other, maybe all three. But what I would say is definitely consider doing them earlier for sure and more frequently than what I think the guidelines recommend as well. What's really nice now is like there's lots of companies out there like Pernuvo that are doing full body MRIs that also look at the breast. So you get more than just a breast MRI, you get the full body. And if you can get one of those, I think regular cadence that's additive to the entire diagnostic pathway. But, it's still critical, in my opinion, that women are constantly and consistently evaluating their breasts, almost to the point of just doing some type of evaluation on a yearly basis, if not one, two, or three.
It's the question that I have now for that is because I've interviewed so many women and doctors on mammograms and QT scans and ultrasounds, MRIs, like what do we do? And it's kind of like the menopause hormone space, like we're all confused. What's the best? It's good, it's bad. Radiation, no radiation. And so it seems as though the technology is getting so good and so accurate. And then if you're going to do something crazy like me and just do all of them, I'm afraid that that the detection is so high and almost too good that it detects almost the things that are benign. And then during that period of waiting, and I've got a friend right now, she called me yesterday freaking out that she's got to get a biopsy because they found something, but she has to go away for 2 weeks. And so I know her life is going to be hell thinking she has cancer and she's going to die because she's got this type of mindset too. And a lot of women do. I mean, it's normal to freak out. So some people would say, well, I don't even want to go down there. I'd almost rather be ignorant because it's too much. Like, how do we find that sweet spot? Or am I completely wrong? It's really not that much accurate.
I'll just answer the question even more broadly. So what I'll say is for all of the testing, whether it be a mammogram, a Grail cancer screening, even just a simple blood biomarker test, right? You have to understand where is your N of one mentality around the data. And so whenever I see a patient, I always bring out this bell-shaped curve and I put on this laminated sheet of paper, I write, I will freak out on one side, or I want all the information all the time on the other side. And I ask them to point to me, where are they on this bell-shaped curve? And some women do point, and men do point on, I will freak out. And then we have the conversation like, look, you should do, if you're one of these people that are going to freak out about any result, we should just stick to what are the guidelines, okay? And let's look up right now, what does the preventative task force say that you should do as a bare minimum, and let's just do that. However, if you point to, I want all the data all the time, I'm going to give you the pathway to getting all the data all the time. Okay. But you have to promise me that if you get a positive result, number one, you're going to need to spend the time, money, energy investigating what is that result. Is it a false negative? Is it a true positive? And so N of one methodology also applies to your psychology around the detection and the diagnosis.
Oh gosh, everybody should have you as a doctor because you're giving us a choice. It's really to have a choice is so empowering, and to have explanations around the choices as well. And that's just absolute gold. So I'm going to have to let you go now. But if anybody does want to see you or go to Next Health and get treated by any one of your practitioners, how can they do that?
Yes, absolutely. Just go to next-health.com and fill in the contact form, and we're happy to see you. We're happy to review any blood work data that you might have. A lot of people have their own blood work now, and they should bring it into us, and we'll review it with you and tell you what you should be looking for. I'm a big fan of biomarkers, and so if people would love to get their biomarkers done, I have a free guide that you should bring to your doctor and ask them to test your biomarkers, including your hormone levels, inflammation levels, etc. It's at drshah.com/biomarkers. And I'm always trying to put some good information out there on social media. And my social media handle is at Darshan Shah, MD.
Awesome. I'll have all of those links in the show notes. And please, everyone, go listen to Dr. Darshan Shah's podcast, Next Health. I'll have that. Extend.
Extend, yeah.
Extend, yeah. So I'll have a link to Extend, and please go check it out. I'll have that episode with Dr. Sarah Gzal as well. Thank you so much for your time, Dr. Shah. I really appreciate your time and your knowledge, and you just keep pushing the needle, keep investigating, keep searching, and I'll be back with you again talking about NAD and what you found out.
Thank you, Zara. Thank you so much.
Take care, and thank you everyone who's made it to the end of the podcast. We really appreciate you spending your time with us, and we will see you next time.